It's called vestibular schwannoma, right?
Vestibular schwannomas.
Schwannoma. Schwannoma. GK.
The broadcast is now starting. All attendees are in listen-only mode.
Good evening, ladies and gentlemen. On behalf of Electa India and our host this afternoon, Dr. Manjul Tripathi, I welcome you to the webinar on Lexel Gamma Knife Radiosurgery for Vestibular Schwannomas. Dr. Manjul is currently the faculty for neurosurgery at the Postgraduate Institute of Medical Education and Research, Chandigarh. Prior to his current assignment, he was a faculty at the NIMHANS, Bangalore. He has authored over 125 research papers and is a recipient of several awards for his outstanding work. He has been a fellow for functional neurosurgery at Oxford and has mastered his skills training from AIMS, New Delhi. His areas of interest span functional neurosurgery, gamma knife radiosurgery, neurotrauma, skull-based neurosurgery, and like a true clinician, the art and science of injuries. Before Dr. Manjul starts, two basic ground rules for smooth execution of this webinar. All attendees would be on mute for the entire duration of the webinar to ensure there is no hindrance to the flow. For any questions that you may have, please type it under the questions tab at the webinar control panel. Dr. Manjul would address them at the end of his session. So without further ado, over to you, Dr. Manjul.
Thank you, Karan, for this nice introduction. And I welcome you all on this webinar on the role of gamma knife radiosurgery for vestibular schwannoma. I request an active participation and would be happy to answer any query at the end of the presentation. These are my disclaimers. PGIMER Chandigarh is an associate member of International Radiosurgery Research Foundation, Lexel Gamma Knife Society, and is actively involved in gamma knife research and clinical practice. I am limiting this talk to my experience with gamma knife radiosurgery. As you are already aware, vestibular schwannoma is the most common cerebellopontine angle tumor. The others are meningiomas, epidermoids, trigeminal and facial schwannomas, etc. It is usually a disease of adult and old age population, and most of them are unilateral. Most of the patients present with hearing deficit, sometimes by vertigo, tinnitus, facial paresis, or motor or sensory complaints of trigeminal nerve such as trigeminal neuralgia or paresthesia. We often detect tumors in early stage only. The tumors with the large size may present with features of brainstem and cerebellar compression, such as gait ataxia, pyramidal signs, or hydrocephalus. So why have we realized any need for discussion today? Compared to the other intracranial pathologies, the level of evidence to provide treatment recommendations for vestibular schwannoma is low. In most of the cases, vestibular schwannoma is either an incidental diagnosis or now they present early because of the hearing deficit in any ear. People come to know about their small tumors when they notice difference in hearing in both the ears while talking on mobile phones. In most of the cases, the diagnosis is on radiology only. Histological confirmation is required only in cases of suspicion on pathology. For small vestibular schwannoma, confusion happens between observation and radiosurgery. For large vestibular schwannoma, confusion happens between primary radiosurgery or secondary radiosurgery or fractionated radiotherapy. Most of the times, the patient is a referred case from general practitioner or your ENT colleague, dental colleague, or a fellow neurosurgeon. And people have different things to say about such a case and the option of gamma knife. The common discussion goes like, do not do anything, it wouldn't grow. The stereotactic radiosurgery does not work. Your tumor is either too big or too small for stereotactic radiosurgery. Even if it works, finally we will have to eventually take it out from your brain. If you get SRS, it would be very difficult to take the tumor out as it might be stuck to your nerves and it will get your face paralyzed. Even if it works, you might develop any cancer as its complication and you will die of the cancer rather than the disease. I should take most of the tumor out, but if something remains and only if it grows, you can consider SRS then. If I cut your vestibular nerve, your disequilibrium would resolve. And fellow microneurosurgeons say that you may become deaf, but the microsurgical results are still the best options for your tumor, hearing, and the facial preservation. CSF leaks, strokes, post-surgery hematomas, deep vein thrombosis are very overrated and rare complications. If I take your tumor partially out, it hardly has any chance of growth. I can make your chances of equilibrium better since your brain will adapt, or I'll treat your tinnitus. These are actually myths, and there are different levels of evidences to refute it. And after all this discussion, the patient goes to the internet and gets further confused about the management. He becomes one of these, in view of the varied opinion, and then comes the role of correct counseling, realistic realization, and the expectations of both the care seeker and the care provider. Most of us who are listening to this webinar today are microneurosurgeons, as I am, and we are aware that the surgical risks have given way to less invasive and cost-effective treatment options such as gamma knife. Now, conduction of any RCT is not viable for considering microsurgery versus radiosurgery versus observation, and the decisions should be based on the current level of evidence, recommendations, clinical acumen, and our expectations. And this is a marvelous quote by a very famous microneurosurgeon, Al Mallis, and he predicted way back 2 decades back that the gamma knife would be the mainstay of vestibular neuroma care in the coming future. The safety, efficacy, and complication profile of gamma knife has made it a primary treatment option for vestibular schwannomas. As a result, most of the centers are practicing gamma knife radiosurgery, which is evident from the trend. This is a graph showing comparative use of microsurgery and radiosurgery for vestibular schwannoma. At the University of Pittsburgh, where graph of radiosurgery is gradually going up, while for microsurgery is going down. It is the same situation at my own institute. When we started in 2009, the number of cases per year was only 21, but it is now 125 cases of sporadic vestibular schwannomas and 11 cases of the bilateral vestibular schwannomas. And this is the latest data from the Lexel Society statistics, showing 1/4 share of the vestibular schwannomas among all the indications worldwide. It is only behind meningiomas in its number. This graph and this graph shows growing popularity and uses of gamma knife radiosurgery for the management of vestibular schwannoma, which indirectly testifies for its safety and efficacy. In this trend, the choice of gamma knife made a change. Up to 3 decades earlier, it was a choice of treatment for failed surgeries, recurrent or residual tumors, high-risk professions, medically infirm patients, but now, gamma knife is the treatment option as a primary mode of the therapy. The management is primarily on the size of tumor and the clinical presentation. It is a rough draft which needs to be discussed with the patient. For smaller tumors less than 3 cm in size, the discussion revolves around observation versus surgery versus radiosurgery, while for greater than 3 cm, the role of primary versus secondary treatment modality. The philosophy of radiosurgery is to treat the lesion as early as possible. We want to hit the target in the early part of its natural history so that we can control it while minimizing the radiation insult and preserving the normal neighborhood of the tumor. This is in contrast to the microsurgery, where usually tumors are treated when they become symptomatic, either because of the mass effect or the cranial neuropathy. Conventionally, we divide vestibular schwannoma in 4 Coos grade 1 to 4. Roughly, a Coos grade 1 is intracanalicular tumor. Coos grade 2 is tumor extending into the cerebellopontine angle system. Coos grade 3 is a tumor touching the brainstem but not compressing it, while Coos grade 4 is a large vestibular schwannoma compressing the brainstem. In this robust analysis, Professor Douglas and his group have compared a treatment with the natural history of vestibular schwannoma. So a patient with newly diagnosed vestibular schwannoma has options of observation or surgery or gamma knife. If one chooses option of observation, then chances are that 77% of these patients may have an enlargement in the size of the tumor with risk of mean decrease in the speech discrimination score by 80%, and tumors may double in size within 2 to 4.5 years. If the patient chooses gamma knife radiosurgery, the chances of tumor control are nearly 98%, with preserved hearing in 64 to 85% patients, and these patients enjoy a good quality of life with no further treatment. If the patient chooses surgery as the first treatment option, then it depends whether there is any residual or recurrent tumor after surgery, and then that can be treated with gamma knife. With all this information and varied opinion, the patient gets confused, especially if it is an incidental detection, and then comes the role of discussion in the light of best evidence to us. While discussing various treatment options, we should focus on tumor growth, progression-free survival, cranial nerve preservation, long-term survival, complications, and the maintenance of the quality of life. Let's start our discussion with the tumor control rate. For a sporadic vestibular schwannoma, there is a good literature showing long-term tumor control rate ranging from 91 to 97% at 5 years in the different series, and 85 to 95% at 10 years following gamma knife. The factors that affect the tumor control in various series are the targeted volumes and the prescription dose. Whenever the treatment was done with a good dose of 12 or 13 gray, the tumor control was better in comparison to the series where the 11 gray was used as a prescription dose. A smaller tumor with a better dose gives you a very robust outcome. Once you treat the tumor, it starts shrinking in size. The usual response is development of central necrosis inside the tumor at 6 to 12 months of MRI, followed by the circumferential volumetric reduction. This is Aku's grade 4 vestibular schwannoma. The blue line is the outline of the original tumor volume at the time of treatment, while in red is the tumor volume at the consecutive follow-up, and you can see the tumor has shown central necrosis at the 6 months follow-up and then gradual reduction. The next and the bigger concern is the hearing preservation. So many a times a patient comes to us with a small Coos grade 1 or 2 vestibular schwannoma and they say, "Dear doctor, I would follow up regularly with clinical, radiological and audiometric evaluation. I do not want any treatment at present." The observation in such a case is definitely an option and should always be explained to the patient, but they should be warned that in majority of the cases, there is deterioration in the useful hearing regardless of the tumor growth, and it happens in the early part of their follow-up years. I see many of these patients going deaf. Recently published consensus guidelines by European Association of Neuro-Oncology provide a level 3 recommendation for observation, but there are hardly any clinical parameters which reliably predict growth in a newly diagnosed vestibular schwannoma. So if somebody chooses an option of observation, they put themselves at the risk of losing that useful hearing in the coming years. In this landmark article, the master group compared the wait and watch strategy versus a proactive gamma knife in intracanalicular vestibular schwannoma, and they found that the median time of losing the useful hearing is 4 years, and most of these patients eventually go permanently deaf. There is now robust data which proves that an early radiosurgery within 2 years of the diagnosis provides you the best chance to preserve the hearing. In addition, the patients with no subjective hearing loss at presentation had better long-term audiometry findings if treated within the 2 years after diagnosis. This resulted in 88% serviceable hearing at 5 years compared to 55% serviceable hearing in the group treated after 2 years of the diagnosis of vestibular schwannoma. So earlier is better. With the time, the surgical armamentarium has also got better, and we are using intraoperative neuromonitoring, ultrasound, intraoperative MRI. Still, the meshed cohort analysis provides some much better hearing preservation with stereotactic radiosurgery compared to the microneurosurgery. The Shreveport group has even highlighted with their experience that the patients might get better hearing after radiosurgery. In my clinical practice, I get this kind of response too, though infrequently. When the patient comes to me and asks me whether my hearing would get better, I always assure them that I would try to conserve whatever the hearing you have as much as possible. I never tell them that their hearing may improve, but actually it improves in some patients. Improvement sometimes only is objective on pure tone audiometry and speech discrimination score. It usually does not happen that a patient with a non-functional hearing at presentation becomes functional after gamma knife. But yes, objective improvement can be seen. So what are the factors which decide a better hearing? If the hearing is good at the time of presentation, you are going to get a good outcome. Presence of tinnitus is actually a positive predictive factor. Patients with young age and smaller tumors do better. Younger patients, better chances of hearing. And you need to preserve the cochlea from the unnecessary radiation exposure. The limitation of cochlea is 4 gray, and you should preserve the cochlea from this 4 gray exposure. In fact, there are long-term studies which indicate that post-gamma knife radiosurgery, hearing deterioration is not different from the presbycusis, and the patient can be assured that if a good plan is made, preserving the cochlea from radiation injury, he can enjoy a good hearing for a very long duration of time. The next in line importance is the preservation of the facial nerve. I would like to remind you that for any patient, preservation of the facial nerve is actually more important than the preservation of the functional hearing, as it affects their social life very adversely. Problems with facial nerve happen less frequently than the problems with vestibular nerve or auditory nerve, as facial is a motor nerve compared to the vestibular nerve, which are actually sensory in nature. And from radiation principles, we are aware that the motor nerves are much radio resistant in comparison to their sensory counterpart. In the meshed cohort analysis, gamma knife radiosurgery provides better overall preservation of the facial nerve in comparison to microneurosurgery. This review is for small and medium-sized vestibular schwannomas. In fact, with gamma knife radiosurgery, facial nerve preservation is a norm, especially the chances of facial nerve preservation are more than 99% in Coos grade 1 to 3 vestibular schwannomas. In this large series of patients, the facial nerve preservation with gamma knife radiosurgery is much better than microsurgery. As evident from this comparison, gamma knife fares better in each domain except for the tinnitus. And you know why is it so? Actually, for tinnitus, you need a functional ear, and gamma knife provides you the functional hearing ear. If you do not have a hearing, there would not be any tinnitus. And if you have a functional ear, you may have a tinnitus. For some patients, tinnitus might be bothersome, but most of these patients adjust to this problem. Let's compare the results with the giants in the field. Professor Sami, in his landmark article, has very impressive result with the hearing preservation in the functional ear in 51% and preserved facial nerve function in 81% patient population. And this is in the best of the hands of the microneurosurgery. Compared to it, gamma knife radiosurgery has a better cranial nerve preservation. If we glance at the literature for the larger tumors, the facial nerve preservation in the best surgical series ranges from 40 to 80% despite the improvement in our armamentarium, better intraoperative neuromonitoring. Even if you use different surgical approaches, the facial preservation is only 84% in the best of the hands. There are some good series with the large volume acoustic tumors being primarily treated with gamma knife. If it is used as a primary treatment option, which we use in medically infirm and complicated cases, the new onset facial paresis is found in 8.3% patients with hearing preservation rate of 50% and progression-free survival of 76%. So the results are inferior than the results for primary gamma knife radiosurgery for Coos grade 1 to 3, but still it is better than the most of the surgical series. And it is not a bad choice for patients in advanced age who are not suitable for surgery. But the best option is a planned partial resection. What we understand for these large tumors is to go inside the theater with a thought in mind that I would remove as much safe as possible, principally core out the tumor from inside, and then give radiation to the remaining tumor after an interval. This provides you the best functional outcome and the long-term tumor control for the large vestibular schwannomas. And this is the best balance of microneurosurgery and the radiosurgery for large volume tumors, as evidenced in the next series of publications over it. This is repeatedly proven in the literature that the long-term tumor control with preservation of cranial nerves can be achieved with a hybrid technique. When we look at the alternative treatment options for large volume vestibular schwannomas, we find that the plant partial resection followed by the gamma knife provides you the best possibilities of tumor control while maintaining the quality of life than any other treatment option. The worst is a surgical insult to the nerves followed by the adjuvant radiation. Hypofractionation has been tried for large and small both vestibular schwannomas with promising results. There are upcoming reports with the fractionated radiosurgery with ICON as well, and we believe that it would be a promising alternative in the near future. But in most of these patients, the functional hearing could not be saved. Various other parameters with various dosing schedule has been used in various fractions, and the results are still evolving. Next important question is the maintenance of quality of life, and studies have supported that patients who received gamma knife radiosurgery enjoyed a much better quality of life than patients who received microneurosurgery. In fact, this study has found out that post gamma knife radiosurgery, quality of life is not materially different from the general population. On long-term analysis and specific evaluation of quality of life with particular parameters such as pan-acoustic neuroma quality of life scale, gamma knife radiosurgery fared than microneurosurgery in most of the parameters. I like this article. This is a very straightforward comparison by John Regis. He has found that 99% of the patients return to their work after gamma knife compared to only 66% who undergo microneurosurgery. And patients with gamma knife radiosurgery take only a week off compared to 130 days off of microneurosurgery, and it's a lot of money. Now, there are a few questions for gamma knife radiosurgery for residual vestibular schwannoma that we leave after microneurosurgery. So if there is a residual vestibular schwannoma, should it be treated upfront or we should wait for a documented growth in the tumor? Well, the natural history of the residual tumor shows other results. This is an excerpt from the textbook of neurosurgery by humans. Literature analysis proves that it remains an option. The observation for a residual tumor remains an option, but it comes at a risk. As 40% show regrowth within 3 to 4 years of primary surgery, and if you treat them after documented growth, the chances of cranial neuropathy increase when you treat them with an increase in the size compared to the proactive treatment when you know that there is a residue. Recently, there are some good articles like this one, which has highlighted that the residual tumor inside the internal auditory canal, which is actually the most common site for the remaining tumor, has a high chance of regrowth of the residual tumor compared to a cisternal component residue. Probably, it is because of the preserved vascular supply of the residual tumor in the internal auditory canal. Especially if the residual tumor is more than 1.34 cc in volume, it has a high risk of growth. The next question is when? Now we know that there is a residual tumor. The repeat treatment is as per the facial nerve status. If the postoperative facial paresis is House and Brackman grade 1 to 2, let's go for the treatment within 3 to 6 months. But if the paresis is worse than that, then one should wait at least 6 months for gamma knife. The reason is that after surgical insult, the nerve takes a time to recover. Giving a radiosurgery at a shorter interval time poses higher chances of injury to the nerve when the nerve is actually recovering from the surgical insult compared to an interval radiosurgery of 6 months to 12 months. The cystic tumors do or do not respond to the radiosurgery. For a very long time, the conventional wisdom was cystic tumors do not respond to gamma knife. But recent studies have proven it otherwise. Actually, cystic tumors respond better to gamma knife in comparison to their solid counterpart. In fact, when it is macrocystic, the response is actually better compared to the microcyst. I do not avoid the cystic vestibular schwannoma from gamma knife. In this article, I especially liked the commentary on this article by Michael J. Link. The most important message should not be lost, and that is tumors that probably have a cystic component respond as well as solid tumors and may be better than completely solid tumors. And the conventional wisdom that cystic tumors should only be operated is not warranted. We have likewise found the cystic tumors responded at least equally well to non-cystic treated with gamma knife. Similarly, tomatoes were thought to be poisonous by most in Europe and America for about 200 years until the mid-19th century. This was a patient, my patient with complaint of sensorineural hearing loss. Surprisingly, there was no clinical feature of brainstem compression, and I treated him with 12 Gray at 50% isodose radiosurgery. And this is his follow-up MRI at 1 year. But one should differentiate a tumor cyst from a benign cyst outside the tumor, like an arachnoid cap. An intratumoral cyst responds best to gamma knife radiosurgery. But sometimes you find a cyst outside the tumor, which is actually an arachnoid cap in most of these patients, and such kind of cysts which are outside the tumor should be operated. So an intratumoral cyst should be treated by gamma knife. An extratumoral cyst or an arachnoid, that should be primarily treated with the surgery, because that arachnoid cyst is actually is not going to respond to gamma knife radiosurgery. For some patients, frame was an issue, but with latest model Icon, even that hindrance is not there, and more patients can be treated with prior planning without fixation of the frame while maintaining the same safety efficacy. And it remains comfortable to the patient. The wheel in and the wheel out time is only 2 to 3 hours for a patient, and they can be back to their work in no time. In strict radiosurgical principles, in the coming slides, I am going to show what are the things which we should always maintain for a quality assurance while treating with gamma knife. One should always get a detailed MRI, which includes continuous, non-overlapping cuts at 1 millimeter interval, and it should be ideally co-registered with the osteotactic CT scans to further minimize the chances of errors in the Y and the Z axis. The tumor should be seen in all the dimensions. Next, you define the target volume on the relevant cut. One should always be doubly checking the extent of intrameatal projection of the tumor. Then we should define the organs at risk. In case of vestibular schwannoma, these are the basal turn of cochlea and the brainstem. Every organ at risk has different radiation tolerance. Regis et al. Established that cochlea should be preserved from 4 Gray radiation injury, and no part of brainstem should get 12 Gray or more radiation exposure. Following this, we put shots and we try to match the 3D architecture of the target volume. We should check the plan on the forward and inverse plan with the best selectivity, conformity, and the gradient index, covering the maximum part of the tumor and preserving the organs at risk. What dose is optimal for vestibular schwannoma? This we have learned from the history. The dose for vestibular schwannoma ranges from 11 to 13 Gray at 50% isodose exposure. The series with good progression-free survival and best cranial neuropathy outcome have highlighted 12 to 13 Gray. The dose should not be less than 12 Gray for vestibular schwannoma in most of the cases. And we should check the radiation is placed to the organs at risk with the dose volume histogram. And then only the treatment should be executed. Like in this case, you can see that the tumor is being treated with the 12 Gray isodose, which is in the yellow line, and the basal turn of cochlea, which is in the blue line, is outside the 4 Gray radiation splage. So this is the usual response. This was a Coos grade 3 vestibular schwannoma. We predicted this response that tumor would regress at 2 years, and then the 3 years there is a gradual reduction in the tumor volume, and tumor is getting further away from the brainstem. How does this happen when gamma knife happens? There are many experimental models on animals which show that it causes a coagulative necrosis, edema, vascular congestion, and hyalinized tumor blood vessels with the endothelial proliferation. In nearly 15% of the patients, the tumor may show an increase in tumor volume on the follow-up scans at 6 months to 2 year interval. This needs to be clearly discussed with the patient beforehand that such an increase might be noticed on the follow-up scan, which is actually a tumor edema secondary to the radiation, rather than an increase in the tumor volume. Hence, this is called pseudo-progression rather than a true progression or failure of the treatment. There is no clear-cut definition of pseudo-progression, and it ranges from 15 to 70% as per different criteria used in the literature. In this landmark article editorial, Marcy Group mentioned that these patients do not need any upfront surgical intervention. What you need to do is to just observe and repeat scans at 6 months or yearly interval if the patient is neurologically intact. This patient showed an initial increase after gamma knife radiosurgery at 3 months in the upper row. Patient had no symptomatic worsening and was just kept on conservative mode, and in the follow-up scans we see that there is a gradual reduction. Similarly, in the lower panel, you can see that a Coos grade 2 vestibular schwannoma actually increased to Coos grade 4, and when they followed it for a longer duration of time, it showed a gradual reduction. We must keep one thing in mind. This is my patient. He also had a pseudo progression. As you can see that the tumor, the contrast enhancing part has increased, but we just followed these patients and then it showed a gradual reduction at 4 years interval. We must keep one thing in mind, that we are treating patient, not the scan. Even if the tumor is increasing in volume, but the patient is neurologically stable, there is no need to jump for surgery. If there is clinical deterioration, yes, one should intervene. This tumor increased in size for 2 years, but eventually regressed at 4 years follow-up, and the patient was neurologically stable. Is there any role of second procedure when the first session fails? The failure is defined as continuous tumor growth even after third year of gamma knife. In that case, the decision for repeat procedure should be done on the basis of clinical and radiological features of the patient, but in no case it should be operated before 3 years with redo radiosurgery, because giving a radiation exposure within a 3-year interval accumulates the radiation insult. But before considering the repeat procedure, be sure again to differentiate a failed procedure from the pseudo progression. There is a usual impression that surgery might be more difficult if the patient has received prior radiosurgery. Actually, it is not. The Marcy group did not find any difficulty in the patients with prior radiosurgery. This might be true for patients with prior radiation therapy like intensity modulatory radiation therapy or external beam radiotherapy, but not for radiosurgery. SAMI group has compared their experience with the primary surgery and surgery in prior radiosurgery and have found no statistically significant difference between the two groups, except slightly high chance of the facial nerve injury in the later group. In the recent study by B.K. Mishra et al. From the Hinduja group Mumbai, the tumor which needed surgery after radiosurgery was firm and arachnoid adhesions were present, but under safer neurological monitoring, the tumor could be excised without new deficit. And in my own personal experience of 4 patients who failed after gamma knife radiosurgery, the tumor excision was not different from a primary microneurosurgery. Gamma knife radiosurgery can be safely repeated. In this large patient population based study, only 6 out of 1,352 patients, which were followed for a good 21 years, needed repeat procedure, and it was pretty safe and effective too. Various long-term studies have proven that it is equally effective and safe. The CNS consensus guidelines give a level 3 support for the same, that when there is a progression of the tumor after SRS, SRS can be safely and effectively performed as a retreatment. Next comes the tricky question of bilateral vestibular schwannoma. There is no fixed rule in such a case, and every case needs to be treated on an individual patient basis. Because you cannot cure this patient, the cornerstone of the treatment remains maintenance of the quality of life and functional preservation as long as possible. This patient population remains a special cohort which should be counseled for the prognosis. Lifelong care and eventually a chance of loss of useful hearing should be explained to the patient and the relatives. Apart from it, the syndromic patients remain at risk of second hit, and radiation-induced neoplasia might happen at a little higher rate. I recommend listeners to go through this article, which has presented various case scenarios and the balanced use of microneurosurgery and radiosurgery for the best functional outcome. The CNS consensus guidelines have highlighted that there is insufficient evidence for primary surgery in patients with neurofibromatosis type 2. Not much has changed since the publication of this article. Radiosurgery is a valuable, minimally invasive alternative treatment for these tumors. For most patients, it controls growth or defers the need for surgery or both. There is a price in terms of hearing function. Although this may compare favorably with the deafness associated with the natural history of the disease and with surgery, in deciding on therapy, patients should be aware of this treatment option. The CNS consensus guidelines have also favored the role of radiosurgery for radiologically progressing vestibular schwannomas or lesions with the hearing loss. The patients may find a worsening hydrocephalus after gamma knife. This is a rare phenomena, and I have found it only with some Coos grade 3 or 4 vestibular schwannomas so far. This is because of direct compression of the fourth ventricle, and these patients may need CSF diversion if they are symptomatic. Sometimes, just because of a pseudo progression, there might be an obstruction in the CSF flow, but these patients settle with the CSF diversion. Some patients present primarily with a balancing problem, and that might be because of their vestibular component. Well, the literature is fractured over this statement, and no single treatment modality is preferred to another for the same. Patients may or may not get a relief either by surgery or stereotactic radiosurgery. Does tinnitus improve after gamma knife? Well, I find it either remains same or sometimes worsen after gamma knife, as patient continues to enjoy useful hearing and sometimes have an improvement in the hearing too. But I do not have any statistics to prove it. Another query which I am frequently asked is, does radiosurgery leads to carcinogenesis? This question has been repeatedly clarified in the literature now, and in the Lancet 2018 article published by Pittsburgh Group and Ajay Niranjan et al., it has been clarified that the risk is so small that it is not different from the general population. Various studies have proven that there is no high risk of malignant transformation in such patients. I have found a couple of reports and series which have highlighted the risk of malignant transformation to malignant peripheral nerve sheath tumor, glioma, meningioma, sarcoma, but this risk is so minuscule in comparison in proportion to the number of patients receiving gamma knife in huge number, and now with the robust follow-up since 1970s. Sometimes you may get a radiation-induced facial nerve paresis that happens 1 in 1,000 cases, or a brain edema, which is usually controlled with a short course of steroids or bevacizumab. Out of my 800 patients, I found it only in one patient who had a functional, good facial nerve and had a grade 5 facial paresis. This patient was controlled with steroids, and then his facial paresis from grade 5 to improve to settle to the grade 4. This was his tumor, and in the upper panel you can see that the tumor gradually decreased in size, and these patients can be managed primarily with steroids. If steroid fails, then pentoxiflin and vitamin E combination or bevacizumab. There are anecdotal case reports of bleeding inside a vestibular schwannoma which was earlier treated with gamma knife. Such cases are extremely rare and need treatment only when symptomatic. This is by my good friend Dr. Nishant Sadashiv, who recently published this article, and probably because of the vascular congestion, it might had a bleed. He operated on it and found an impressive good result. But I couldn't find much more literature over it apart from a few case reports. Trigeminal neuropathy. Some patients, especially the larger tumors ones, which are impacting the nerve or the root entry zone, in these patients, you might find a subtle transient sensory disturbance in the form of paresthesia. But it is a very subtle phenomena. It's hardly any time bothersome, mostly controlled with a short course of amitriptyline. Only tumors with the Coos grade 3 and 4, they sometimes present with this phenomena, and within a couple of months, they improve on this on their own. Another argument which frequently I find in the conferences when the people ask that patient is young, remove the tumor, he will be cured for life. Surgery is definitely with a curative intent and a very valid option, but only if it can be done safely, elegantly, without creating a deficit. That too in a young patient whose social and vocational life is depending on his functional status. In such a case, gamma knife reduced surgery remains a valid treatment option. Finally, the question remains, what would you prefer if the same thing happens in your own head? And I always find whenever I go in debates with the microneurosurgery groups also, I find all hands preferring gamma knife reduced surgery except for a couple of hands in favor of surgery. Most of the people want gamma knife because everybody wants to be safe. And this was the level of evidence in the ISRS practice guidelines. Is single fraction SRS is an option, and 100% of the attendees they favored for acoustic grade 1 to 3 vestibular schwannoma the gamma knife reduced surgery. In the last, the cost effective analysis. Gamma knife is much cheaper than surgery both on the initial cost and the follow-up cost evaluation. I like this slide from L. Del Lunsford and what has gamma knife reduced surgery made a change in last 20 years. This was his slide in 2012. It reduced the expected number of post-op deaths by 1440, eliminated 2400 hematomas or infarcts, prevented more than 10,000 CSF leaks, prevented facial paresis in nearly 17,000 patients, and prevented deafness in 36,000 patients. So the take-home message is that facial neuropathy is less than 1%, trigeminal neuropathy less than 3%, hearing preservation very robust, 85% for the intracanalicular tumor, 75% at 5 years for Coos grade 2, 3, and the tumor control rate in the range of 97 to 98%. And not only vestibular schwannomas, other schwannomas also respond very well to gamma knife reduced surgery. So this patient presented with a huge trigeminal schwannoma, treated with gamma knife and practically melted within 1 year. This is his coronal view. This is a trigeminal schwannoma. So schwannomas respond very well to gamma knife reduced surgery. The future of vestibular schwannoma management is going to be guided, apart from these data, the immunological parameters, BED calculations, and the dose fallout. These are some good suggested readings, and all the interested readers, I encourage them to go through these readings because they provide a very good ready reference. So I do not think that there should be any issue in accepting this fact that we should let go of our ego, and a preserved cranial nerve is a better option. Thank you very much.
Thank you, Dr. Manjul, for the informative webinar. I can see that there are already some questions in. Perhaps you would like to answer them.
I'll go through them one by one. So, how do you compare with CyberKnife? That's a very good question. So, in the literature analysis, as we go through the CNS consensus guidelines, we find that results are nearly the same. But if we go with the organ preservation and a better conformity planning, the gamma knife always fares over CyberKnife reduced surgery. And for this, I would like to quote an article by Jeevert et al., where they compared the gamma knife, CyberKnife, and the Novalis platform with the similar tumor and the planning over them, and they found that the best conformity and the selectivity could be achieved only with the gamma knife reduced surgery. So I am seeing another question by Dr. Rajratan. Sir, do you foresee gamma knife reduced surgery as the gold standard treatment for vestibular schwannoma in the near future? That's a good question. To make something a gold standard, that should be acceptable to all with the better safety and the complication profile. Surgery is always with a curative intent. When I counsel the patients, I always counsel them that the tumor would shrink. It would shrink to a significant extent, but you might see a tumor in your follow-up scans. But it is not creating a trouble to you. You would have enjoyed the same good quality of life with the better hearing preservation. So if in the long term we see the progression-free survival and the cranial neuropathy improvement, I consider it as a gold standard, at least for the Coos grade 1 to 2 vestibular schwannomas. That's a good question by Dr. Andre. Does proton therapy has any advantage over gamma knife radiosurgery? Dr. Andre, the proton therapy, which is getting popular day by day, has a good radiosurgical principle of a break peak. So considering that, we find that in the proton beam, we do not have an exit dose, which we find with other kind of the treatment modalities like gamma knife, cyber knife, or novelis radiosurgery, LINAC radiosurgery. So in that case, the exit beam or the exit radiation is not there. But vis-a-vis comparison, a straight comparison of the proton beam with the gamma knife radiosurgery has not been done so far, and there is not a very good robust literature over it. So the level of evidence to support one therapy over another one is actually not there. I would like to, because the proton centers were quite a few in the world. We recently in India had a proton center now, so the results and the literature is gradually upcoming, and probably in the coming future we would be wiser to see the which treatment modality has given a better result. For Coos grade 4, what is your brainstem dose acceptance? For a Coos grade 4 vestibular schwannoma, Dr. Anto, if it is a Coos grade 4 vestibular schwannoma, always the brainstem should be kept away from a 12 gray radiation exposure. So in that case, the prescription isodose, sometimes you need to decrease to 11 gray, but we should try to preserve the brainstem from a 12 gray radiation exposure as much as we can, and at no time more than 1% of the brainstem should receive a 12 gray radiation injury. So our planning should be such that the brainstem should be away from the 12 gray line, and only the tumor should be treated with 11 or 12 gray radiation isodose. Can such tumors be treated using neutron capture therapy? I'm afraid actually I'm not very familiar with the neutron capture therapy, and I'll have to go through the literature or ask it somebody else. I'm really sorry, I do not have an answer to this query. What is the maximum possible volume of vestibular schwannoma amenable to gamma knife? As I showed in my presentation, the optimal size is less than 3 centimeter. Less than 3 centimeter becomes Coos grade 1 to 3. In more than 3 centimeter, even in 3.5 or 4 centimeter tumors, you can use gamma knife, but with a lesser dose. So the maximum possible volume that becomes shouldn't be more than 19 or 20 cc. That becomes on a higher range. In those cases, it's always ideal to downstage the tumor with surgery, decrease the tumor volume, and then for the remaining tumor part, we can give gamma knife radiosurgery. But the ideal treatment always remains up to the 3 centimeter in size, because when we give a treatment, a radiosurgery for a tumor up to 3 centimeter, we maintain a very good precision and sharp dose fallout. Dr. Andre has asked, thank you, maybe in a second irradiation after gamma knife. Yeah, might be an option there, but I do not find usually any need for any second procedure, as in my own series I have found that out of nearly 810 patients, only 3 patients needed a repeat gamma knife radiosurgery when they had an increase in the tumor volume later on. I would be happy to have more questions if there are any. Yeah. Quality assurance and the image guidance in gamma knife versus cyber knife versus GKRS. Yes. So quality assurance and the image guidance have been found best with the gamma knife radiosurgery. And this quality assurance check has been done by the Jivat et al. And that article I would request you to read. It's a very head-to-head comparison between these different machines, and they have found that the best dose fallout, preservation of cochlea, and radiation is placed to the surrounding structures was found with gamma knife compared to the cyber knife or any other radiation technique. What is your follow-up protocol for the follow-up MRI? Yeah, so I get the first MRI after 6 months of gamma knife radiosurgery, and then at 1 year. For 3 years, I get an yearly MRI. Whenever I get an MRI, I co-register that MRI with the MRI at the time of the treatment. And a co-registering helps you in showing how is the tumor decreasing. If there is any increase in the tumor volume, it shows at what part of the tumor it is actually showing an increase towards the cerebellum, towards the cysternal component, where is it increasing. So it gives a very good comparative analysis. In a recent article which was published in Journal of Neurosurgery, the authors have found that at 6 months, it is usually not needed because the maximum change is seen at 1 year MRI. I still go with the 6 months MRI, 1 year, 2 year, 3 year. And when the tumor is showing a predictable response and a gradual reduction in the tumor volume, then I do MRI at 3 years interval for a decade and then at 5 years interval. Whenever you have to choose between microsurgery and gamma knife radiosurgery, for any vestibular schwannoma, which one would you choose? Microsurgery, then gamma knife radiosurgery, or gamma knife radiosurgery and then microsurgery? Dr. Rupesh, we do not choose a treatment for a patient. We give options to the patients with the expected outcomes and the best results that we can give to them. So when there is a Coase grade 1 to 3 vestibular schwannoma, patient is young, with a preserved hearing, preserved facial nerve, I tell them that the results of gamma knife radiosurgery are better than microneurosurgery in your case. If they want a curative intent and they say that I do not want any tumor in my head, definitely that patient should be treated with surgery. But it hardly happens. Because with surgery, even in the best of the hands, even with my full neuromonitoring, I find that I can preserve a facial nerve in only 70 to 80% of these patients. In 10 to 30% of these patients, they have some sort of the facial paresis, and that adversely affects the quality of life. So I explain all these things. But if the patient is having a Coase grade 4 vestibular schwannoma with a brainstem compression or cerebellar symptomatology, I always take the patient first for the microneurosurgery, a planned partial resection, followed by an interval radiosurgery. What technological improvements could there be in a gamma knife apparatus? So one good improvement which happened now was the frameless gamma knife radiosurgery with the latest model of Icon. The earlier models up to perfection, they were frame based. Some patients had a claustrophobia or they had a problem with the frame fixation. So in those patients, the frame was actually a trouble. Most of these patients tolerate the frame very well. So that technological improvement has happened with the Icon when the patients can be treated with the same radiosurgical principles, maintaining the same quality, accuracy, and conformity. The second improvement, which I predict in the long term may happen, is that a smaller um, a smaller target, like because the last one which we have is a 4 millimeter. If we can get by any physical mean a smaller target than that, the short diameter less than 4 millimeter, then we would be able to achieve a more conformal plan. Cochlear tolerance dose is 4 gray, a max dose or mean dose. So when we check the cochlea, we try to check it on the DVH, that is the dose volume histogram, as you can see over here. So the cochlea, not more than 10% of the cochlea should receive 4 gray or more. It's always better to keep it towards the zero. No part of cochlea should receive 4 gray or more radiation, but the acceptable range is 10% maximum of the cochlea should receive a 4 gray radiation exposure for a good preservation. As the prescription isodose line is 50%, the maximum dose inside PTV is 100%, which is twice as the prescription is 50% isodose line. What is the maximum dose inside a plant tumor volume? It's a good, intelligent question over here. A very good question, Dr. Mohammed. So when we prescribe it with the 12 gray at 50%, that means that this yellow line over here, which I am trying to overlap with the red line of the tumor, up to that part would receive at least 12 gray, and inside this yellow line, the tumor would get a 12 to 24 gray of the radiation exposure. So the maximum radiation would be 24 gray. Principally, gamma knife is a heterogeneous dose distribution. So if you go with a point dose evaluation inside this target volume, the radiation exposure would be somewhere around 12 to 24 gray, and it does not affect the treatment outcome. And beyond this yellow line, there is a sharp dose fallout, and as you can see that after 12 gray, the 4 gray is up to here only, and if you go further 2 gray, it would be further less. So the maximum dose is 24 gray. Yes, that would be inside the PTV, and the minimum dose would be 12 gray. This is a heterogeneous dose distribution, which is characteristic of gamma knife radiosurgery. Apart from T2 and T1 post-contrast MRI, do you suggest any specific series for better visualization? Yes. Sometimes I get a CIS image. I want to have a better visualization of the cranial nerves. In those cases, I get a CIS image and I co-register it with the T1 and the T2 so that I can have a better visualization of the geographical location of the nerves in relation to the tumor. Especially for a Coos grade 3 tumor or 4 tumor, I try to do it and I try to preserve the trigeminal nerve from unnecessary radiation exposure. Is it possible to calculate the TCP and NTCP? Dr. Ged, I would be obliged if you can please tell me the full form of these terms, the TCP and the NTCP, as I am not aware of it. So I would like to see it in your question. And Dr. Andre is saying thank you very much, Dr. Andre, for attending this webinar. I hope it's useful. What is the maximum conformity index, 1, 2 or more? Okay, so in gamma knife we see our treatment parameter on few things. I'll show you over here, just a sec. Yeah, so there are 3 terms over here. That's our sequence: the coverage, selectivity and the gradient index. The coverage means whatever the tumor you have marked, how much of the tumor is actually covered by the radiation, and in this particular case the coverage is 98%. I always try to keep my tumors covered more than 98% or 98%. The selectivity is that how much of the radiation is actually in the tumor and how much is going out, so that's 92%. A good selective, it should be as near to 1 as possible in the best case scenarios. A good selectivity plan with 1, that means that only the tumor is getting the radiation and no part outside the tumor is going any radiation at all. So only the tumor should receive the radiation, nothing outside. Here 92% of the tumor, 92% of the radiation is actually on the tumor and 8% are settled in the surrounding areas, which might be towards the extrameatal component. A gradient index, which is the Paddy gradient index, it's a 25% versus PTV 20, the radiation is placed to the 25% isodose versus the 50% isodose. The ideal range usually happens for the good treatment plans 2.35 to 2.45. That's why I always encourage people to make multiple plans with the forward planning, with the backward planning, and the plan which is best in these parameters of coverage, selectivity and gradient index, that should be chosen for the treatment. What is your opinion for Avastin to NF2 patients in comparison to stereotactic radiosurgery? A very good topic. I had my own analysis of patients and I published it recently for, as you can see over here, the role of bevacizumab as a prophylactic and rehabilitative treatment option in cases of sporadic and syndromic vestibular schwannomas, the 50 shades of gray. So, if you search, there are multiple drugs for NF2. These drugs are bevacizumab, lapatinib, mTOR inhibitors, everolimus. But among all these drugs, Avastin is the only one which has shown some response to the vestibular schwannomas for in cases of the neurofibromatosis type 2. The maximum work on it has been done by the UK Neurofibromatosis Society, and it has been found in my own experience also. I used this whenever some trouble happened, not as a prophylactic in our patients, but they have used as a prophylactic measure in some of these patients. So it arrests the tumor growth and sometimes it reduces the tumor size. The neurofibromatosis type 2 patient has a propensity to develop multiple tumors, which includes vestibular schwannomas, ependymomas, gliomas, and meningiomas. So the vestibular schwannomas either grow in a tumor growth arrest or they show a subtle reduction in size. Meningiomas show no response to bevacizumab or Avastin. Ependymomas, especially the spinal cystic ependymomas, they reduce beautifully with bevacizumab, but there are multiple questions over it. First thing, how long to give the bevacizumab, because there are chances of the rebound increase in the tumor when you take them off from the bevacizumab. And bevacizumab is not a very easy drug. It's a costly drug and it is not a very safe drug. Sometimes patients have a complication when it is given in the long term, like the cerebrosinus thrombosis, bleeding, gastrointestinal bleeding, and sometimes with the psychiatric complications, as I published in my experience with the bevacizumab over it. So yes, it has a prophylactic treatment option. The CNS consensus guidelines give it a level 3 evidence, but we do not have an endpoint of treatment for these patients. I hope I answered your query. I heard about a new platform, Zapex, basically a gamma knife without the vault. Do you think there is a future for this? I recently saw that machine when I went to CNS last year, and I found that there is a new radiosurgery machine, but I do not have any practical experience over it, and there is not much literature. It's an upcoming one. It's made by the John Adler, who was the inventor of the cyber knife, and I have to see what happens with the practical application of that machine. But till now, I am finding that the gamma knife provided the best results, and the literature with the Zapex, when it would come in a couple of years, I would be in a better position to give a comparative answer. The tumor control probability is referred to as TCP, and normal tissue complication probability is called NTCP. Oh, thank you very much for that. I didn't know that. So the tumor control probability, or I can say that is the progression-free survival. That is, with gamma knife radiosurgery, 95 to 97% up to 5 years, and 91 to 94% up to 10 years. I am not sure of normal tissue complication probability, which is called the NTCP. I have not found this statistics so far with gamma knife radiosurgery. Might be I'll have to go through the literature again to answer this question, Dr. Kamlaksh. Mainly radiotherapy terminology and one of the measures for evaluating the treatment effectiveness. Oh, thank you very much. I was not aware of it, but I'll definitely go through it.
Thank you, Dr. Manjul. I think that's all that we have for now. Plus, we've, I think, also crossed our time that we allocated for the webinar. So, any closing remarks, sir?
Discuss with the patient, give them all the options, and let the patient decide for themselves. What do they want? We can help them in choosing the decision as per their presentation, their expectations, and our own results. When I say that gamma knife radiosurgery is going to be the next future, because to provide a good result, everybody does not give the result of Masjid Sami. If you can give that result, go for surgery. No problem. But we should consider our own surgical skills, and with that, we should counsel the patients. Because the results of gamma knife radiosurgery are reproducible throughout the world uniformly, but the surgical results are not uniformly same. So the patient should be counseled with that thing in your mind. Thank you very much. I hope this presentation would be helpful to you in having a better understanding regarding the gamma knife radiosurgery for this very common disorder.
Thank you. Thank you very much, Dr. Manjul. And I would also like to thank all the attendees that took our time this afternoon to come and hear us on the presentation and on gamma knife radiosurgery. Hope you have a great weekend. Thank you. Bye-bye.
Thank you.